Thank you, Dr. Bond, for the introduction and also for having me here. Thank you, faculty. So this is a very interesting case, multifaceted with many layers, and a nice one to end up on. So I'll get right into it. This patient, Claire, is a 72-year-old white woman. She presented to her primary care office 4 days prior to going to the hospital with acute onset of a burning type sensation in her chest. She reported active symptoms while in the hospital and described it in a vague fashion, as which was reported. An electrocardiogram was done. It was reported as non-ischemic at the time, and she was referred for a routine follow-up with an outpatient cardiologist. When she went home, she continued to have this chest pain, stuttering in nature, brought on by exertion and relieved with rest. She is a retired nurse, so was very concerned 4 days after when she started having nausea and vomiting and continued burning sensation. And in light of these ongoing symptoms, she went to the emergency department. So this patient has several risk factors for CAD. Her age being above age 55, she's postmenopausal, has a family history with a mother who had an MI. This was in the early 60s in age. She denied any toxic habits and is not on any medications. I mentioned that she was a retired nurse. So Dr. Bellamkonda, I'd like to ask you a few questions. One, in terms of the new ACC/AHA guidelines, the chest pain guidelines released in October, the nomenclature is kind of, they're shifting this from the use of atypical. So they're saying that atypical is out, and rather the nomenclature of non-cardiac is in, as the thought process being that atypical is somewhat synonymous sometimes on paper with a benign process. So can you walk us through the signs and symptoms of heart disease? And also, do you believe this factored in to the management that was suggested by the PCP? And also, what would you do if Claire was in your office?
So we should still remember that chest pain is still the most common, symptom that both men and women present. And women have more associated symptoms, probably shortness of breath, fatigue, back pain, things like that. I do agree atypical is out. So and then non-cardiac gives us a better diagnostic approach, because if it's cardiac versus non-cardiac, and if I tell a patient you have non-cardiac chest pain, they're going to ask me back saying, okay, what is causing chest pain, right? So you do want to get an accurate diagnosis there. So I think that way, diagnostically, it's really helpful. Having the EKG in the primary care setting, looking at it, I think that's what I would do first. What did the EKG show? And then if she presents, I would probably repeat the EKG and get labs, done.
Thank you very much. And we can see on this slide a lot of those which were called that are atypical, and you can see that these additional symptoms we have to look for commonly in females. So she came back to the ED, and this was 4 days after onset of symptoms. This is her EKG, which shows sinus rhythm, deep Q waves in the precordial leads, IV interventional, IVCD, and she has diffuse ST elevations in her precordial, most prominent in the lateral precordial and also the high lateral leads. So I'm going to ask our interventionalist, let's start with Dr. Naik. What would your next steps be and why?
So if you can hear me, right? If you show a nail to a carpenter, he's going to hammer it. So you showed me this EKG, I'm going to do a coronary angiogram.
Okay, and would everyone of the interventionalists agree with that?
Yes, definitely.
Okay, well, I had to ask. All right, So we're gonna skip this for sake of time. So she, let's see. So just as you all would, the doctors loaded Claire with aspirin, full dose, ticagrelor 180, 5,000 of heparin, and she was taken emergently to the cath lab. And also for sake of time, we're not going to show the whole angiogram, but it was interpreted by the angiographer as diffuse, completely occluded LAD in the midsection with a large thrombus burden. This was treated with multiple runs of penumbra, mechanical thrombectomy, which is a vacuum to suck up the clot, and it kind of breaks it up while it's doing that. The mid aspect of the left anterior descending artery, all the way kind of to the front where it started, which is called the ostium of the left anterior descending, was stented all the way back. And there was restoration of Timothy flow, which means it went from no flow down that artery to complete flow. There was a diagonal branch, which was a large branch off of that vessel, which also had minimal obstructive disease, and the other branches going to the right side and then to the left side and the back, called the RCA and the circumflex rib, with no significant disease. They did a ventriculography, which showed an ejection fraction, which was decreased at 35 to 40, normal being above 50 to 55, and the pressure in the heart was normal at that time. So these are the patient's presenting labs. These are labs of a patient who already appears quite sick. You can see she's quite, her renal function is off. She has a BUN of 41, and she has a creatinine of 1.67. The liver enzymes are elevated with AST of 96, and the ALT is 69. Bilirubin is already up at 2.5. And then the patient is also hyponatremic at 129. So this patient is already showing signs that she's quite sick, and she has some organ dysfunction going on systemically. So that being said, I would like to ask Dr. Mamas, at this point, given the story of the presentation, and now this suggestion of some multi-organ dysfunction, what would you do at this time, and what further testing would you be considering at this time?
I mean, certainly in terms of what the LV function has been reported as at 35 to 40%, these labs seem very much out of sync with that, the deteriorating renal function and deteriorating liver function. So I would certainly be wishing to, number one, undertake an echo, a proper echo, not an ventriculogram, to fully assess for any mechanical complications. And number two, also understand how much contrast was used during the cardiac catheterization. You know, could the deterioration in renal function be a function of contrast-induced nephropathy? So I would certainly want to get the renal physicians involved very early on.
Okay, and another thing, so the troponin has now come back. It's 42.14, which is suggestive all of this in combination. In her presentation 4 days ago, the thought process was that this is possibly something that was late presenting, and as per your suggestion, sorry, I have to go back real quick. For the panel, especially actually Dr. Nseir, given these labs and given the patient, she's hemodynamically stable, but there's something brewing right underneath the water. Would this patient be going to the intensive care unit or the regular tele floor? And what is your thought process?
No, definitely she's going to the intensive care unit. I mean, she's an elderly lady. This is day 4 of a subacute MI. She had proximal LAD occlusion. Yes, her hemodynamics, you know, they're stable, but they're probably fooling us with an increase in the BUN and the liver function test. So I would categorize her as like pre-shock. It is almost getting close to a shock. And definitely she should go to the ICU and being observed very closely. And an echocardiogram like immediate echocardiogram like Dr. Mamas suggested to see if there is any mechanical complications. The V-gram is 2D, and sometimes it can fool us. It's yeah, 35%, but you'll be surprised the echo might be lower.
Thank you both for that. So as you two suggested, the patient did go to the intensive care unit and a immediate echocardiogram was done, stat. The patient did remain hemodynamically stable at this time and was actually feeling better after the revascularization. So Dr. Bellamkonda, we're gonna, can you see the echo? We'll run through it.
So that's 2D echo pictures, parasternal long axis. We don't see any pericardial effusion. So the septum is moving okay, at least the proximal part of the septum. That's tricuspid valve.
This is the
So RA is
RVN.
mildly dilated, probably RV is dilated too. So that's, we do see some tricuspid regurgitation, so that's indicative of pulmonary hypertension. And then overall EF about still, 40, 45%. In this view, the septum looks down, but that's aortic valve, it's opening well. So this is apical 4-chamber. LVEF is probably still about 40%. There is some TR, that's the mosaic color that you see. And the RV is probably mild, moderately dilated. So in this view, this is really important. That's the interventricular septum that you see. And there is a definite defect with left to right shunt, the blood flow from LV to RV directly. So that's a intramuscular VSD, most likely a complication of the ST elevation MI. Yeah, that's the shunt from left to right. It's a large defect, 1.2 centimeters. Yeah.
Okay, so you would say that the EF is down and that there's a large shunt, which looks like ventricular septal rupture as a complication of the late presentation MI. This was, the patient was in the ICU, remained hemodynamically stable. Given all of the information that was presented before, this was a conclusion that especially with a elderly lady with her first MI and late presentation after symptoms, that this was a late presentation MI and a complication of that. The patient, it was discussed with her and her family that although she appeared hemodynamically stable now and symptom-free, that these have very, very grave prognosis when you do get these complications if not addressed immediately. As a result, the decision was made to transfer to a higher level of care from this hospital, and cardiothoracic surgery as well as the structural interventional cardiology team were consulted for possible evaluation of percutaneous versus surgical VSD repair as a possible option. So this is a timeline, a screen of the timeline of what can happen after myocardial infarction. So I'll ask Dr. Naik if you could kind of walk through this timeline, the complications and when to expect it after a myocardial infarction.
So she had Q waves on her EKG. So you kind of just based on her presentation know that this probably happened a few weeks ago or a couple of weeks ago, just the way she was describing her symptoms, at least from your slide. So generally what we try to get to the MI with before 12 hours of symptom onset, because we know that there's less complications from that. But afterwards, we consider Brady arrhythmias or ventricular tachycardia. After 24 hours, if we haven't fixed the MI, then we start seeing late complications that are more serious, such as cardiogenic shock. And then after 3 days, we start seeing mechanical complications, such as what you see here with a ventricular septal defect, severe MR, or with a ruptured papillary muscle or ischemic papillary muscle, or rupture of the free wall and either death or pseudoaneurysm formation.
Thank you very much. I have a question for Dr. Nseir. You're leading up a big shock protocol. So in cases like this, where you're seeing a mechanical complication such as a ruptured VSD, is there any role in mechanical support or the shock team? Do you have a protocol which may be helpful before these patients start to spiral, or in the process of getting them to a higher level of care?
Well, I mean, regarding the mechanical support, maybe, I mean, we have to also take into consideration she's an elderly woman and the complications of large bore access. So probably before that, I would like to see a right heart cath and see, you know, what her numbers are and her hemodynamics on the right heart cath, and to make a better decision about the hemodynamic support.
Okay. And Dr. Mamas, I would like to hear from you as well. And so it seems like there's a very narrow window in this patient or any patient like her. At this point, do you have any ideas of suggested management in terms of how to support the patient until you can get to a definitive treatment?
I guess mechanical support is reasonable. Implanting mechanical support is associated with vascular complications, but using ultrasound would negate that. And we do TAVIs on female patients like male patients. I don't think the sex should be something that we should consider in using mechanical support for this lady. Personally, I think that we really do need to get to a center that can offer percutaneous or surgical treatment of VSD. In my experience, and again, you know, I don't see many of these cases, thankfully none of us do, surgeons generally don't take these sorts of cases on, and invariably they get treated percutaneously. In the UK, we're currently taking part in a national registry of these sorts of cases to look at types of patients that get surgery, types of patients that get percutaneous coronary percutaneous VSD repair, and looking at their outcomes as well.
Okay, thank you for that. So as mentioned, Claire was then transferred to a higher level of care institution and evaluated by the surgeons and the interventional cardiologist. I have some clips. I'm going to defer to Dr. Brady and Dr. Naik. If we could walk through the process. First of all, how you decide surgery versus percutaneous. So this is to both of you. Second of all, like what assessment prior to this, if you know, that you look into even before offering anything, and then the technical challenges and technical steps of fixing it in one way or the other, and we'll go through your videos.
So, because I've got to talk first, because I don't want to get ahead of me. First, for the audience, I think we should back up and think about what we're dealing with here. This is extremely rare in today's age. Dr. Mamas had talked about not seeing too many of these, and I consider myself a busy guy, and I still don't see too many. But in the day, before rapid revascularization strategies, these were more common. They probably maybe 2% of acute MIs developed a situation like this. In today's world, maybe 0.2%. So when I came to town, you know, we did these, unfortunately, probably once a year. Now we don't see them for about 5 or 6 years. But this is the ultimate. Everybody's got a plan to get hit with this, and this is devastating because people don't see it very often. Sometimes it goes unrecognized, and we do see it. It's a scramble to try and figure out how to fix it. But this reminds me of aortic dissections with vascular compromise or an 80% burn, second degree or third degree burn. No matter what you do, the outcomes are going to be pretty bad. And I think you need to first recognize that these carry with them about a 90% mortality rate within a week. And like an aortic dissection, right? And it's 80% mortality if you don't do something in 72 hours. So they're time sensitive, they're rare, and they require the expertise of a facility that can deal with it. We talk about percutaneous, we talk about surgery, but there's a reason why people shy away from this, because regardless of the therapy, you're dealing with a very sick person who's in shock. Because we talked about hemodynamic stability, but let's really think about that for a sec. She's not hemodynamically stable, right? She's already got worsening renal function, worsening hepatic function. I guarantee her blood pressure 3 days before she came to the hospital was not normal. And I guarantee that LV may look 35, 40% to you, but unloading into the right ventricle is part of that. And I think that was probably more stunned before. So you're already in a difficult situation. And now you got to find a place that can take care of it. And I'm not just saying this because I run the the MCS program, but mechanical support is probably your best ally. And I would say that as things are evolving, that I would say that's a big step that needs to be considered. But MCS is like having a car. Everybody thinks it's a great idea, but not everybody owns one, and not every car works all the time. So actually getting the appropriate therapies in the hospital, it's not as easy as you think. Remember, the best hospitals that have or the situations where it's a failure to rescue is because you can't take care of the patients. And so you've got to have the devices. Everybody wants to have the devices. Everybody loves to have it, but not everybody owns those devices, and not everybody has the expertise to put them in, or even so manage them afterwards. So I'd say I'd start this situation by being in a predicament, and she's already behind the 8 ball at this stage. We've got worsening hepatic function and renal function. That's not going to get better even if you fix it. She's already gone into cardiogenic shock, and now we've got a situation that this is truly a surgical or percutaneous situation. And that's, well, Hursh and I kind of look at this situation and what's best. We both want to fix this. So I want to just say that when you think about these mechanical holes, they're either right coronary artery or LAD territory. The necrosis has eaten through. So you saw the hole in the echo. Well, that's sort of the tip of the iceberg. What you don't see is that whole area around it is necrotic. It's partly dead, partly dying. None of it's going to hold a stitch. None of it's going to hold a device. So now you've got a situation where, again, you're in a predicament about which one's going to be better. And much like we talked about the CABG and the invasiveness, in this situation, when they're really sick, percutaneous intervention sort of makes some sense because you're in a situation where you're going to make them worse by opening the chest and have to do things. But I think each one individually should be taken for what they are, because not everything can get better unless you can do it right. So I would say right off the bat, I'm a big proponent of mechanical support. And so if you're in a hospital that has, say, a tandem heart, which is a left atrial, so you go transeptal left atrial drainage and into the right femoral artery or into the femoral artery. So it's a circuit to unload the left ventricle that can be used. ECMO, if you have it, anything to decompress, because whatever you're using for support, I guarantee you after you fix it, you may need that support afterwards. These are very sick hearts. You may fix the hole, but they're still infarcted and they've still had the therapy and they're in shock by the time you're actually treating. So I think I'd start by saying that there's no right or wrong answer on surgical versus percutaneous. Yeah. I think the real thing is how can you stabilize the patient? And these mechanical support, whether it's an Impella or a tandem heart or an ECMO, they're great, but they're not always available. And even if you have them in your institution with COVID going on, a lot of these ECMO support devices are literally unavailable to you. Even if we won the busiest ECMO programs in the country at Dignity, you may not have a device when you need it. And unlike somebody on the vent where you maybe can keep them going for 6 or 8 hours, that's not, I mean, this needs to go. This is part of the shock protocol that we're trying to implement, making sure devices are available. So I think Hursh and I with the discussion about somewhat of the hot potato, who's going to go. We know the treatment is of utmost importance and it's time sensitive. And I think a lot of times I would say it's like the burn patient. I don't know if anybody's worked in a burn unit, but when I used to do burns when I was a resident, it's amazing how good everybody looks for the first 24 hours. And then you see this progressive decline, dehydration, infection that sort of comes with it. And it's sort of like that. The damage is done and it's already going on, even though they look clinically to you like they're not doing too badly. So I'd first say by saying the first thing is support and mobilizing a game plan. And so the second thing I want to say about this, because that's kind of long-winded, is everybody wants to wait, because even though we're in shock, the tissue is not going to hold the stitches and it's not going to hold a VSD device. It's going to rupture. You can actually make the situation worse with a device. You may want to go percutaneously, but if that device slips or doesn't completely close a hole or a necrosis around it, then you could be in a worse situation than you sort of started with. If we can get these patients past a certain time frame, they will do better. So the mortality for the operation, if you operate within 24 hours, is over 60%. So just put in my frame, when I talk about high risk coronary bypass surgery or high risk valves, I'm talking maybe 8%. There is nothing we do with a 60% mortality rate. It is literally the highest mortality rate surgical procedure you can do is this one. Second only to, well, probably first ahead of an aortic dissection. So I just want to bring the context of what high risk means. If you can get these people out a couple of days and maintain them, and you get them over, if you can, sort of reverse the shock situation and you can let some of that necrotic tissue get better, the longer you wait, the mortality drops. So if you wait 7 days or I think 14 days, your mortality rates start approaching 8%, 60%, 8%. You can see how we really want that time to get that muscle stronger to hold your stitches and get the person out of cardiogenic shock. So on one hand, you have a surgical emergency or a percutaneous emergency. On the other hand, there's a lot of things to waiting. So you can see why people are hemodynamically stable. There's this idea, if we can get them through a longer period of time and get them unloaded and stable, they're going to do much better with the surgery. And so it's a dichotomy, right? You're kind of caught between two places of how you want to manage these patients.
Thank you very much, Dr. Brady. So we have two beautiful examples, surgical and percutaneous, but we're kind of pressed for time. But I'd like to hear from Dr. Naik, if you could briefly tell us what considerations you have in terms of the technical considerations going into these procedures.
So, just to repeat, I think the goal is in these patients is to decrease their left atrial pressure, improve oxygenation, and improve forward flow. So I think circulatory support early on is important. If you look at, there's an elegant paper by Dan Burkhoff where he compared ECMO, tandem heart, Impella, and all that. And the best support you can give someone is probably ECMO plus Impella, just for unloading and forward flow. So that would be first. And then technical considerations would be, again, for percutaneous at least, is you want to wait as long as you can. And so sometimes that's a difficult game because you can wait and then suddenly they just decompensate, it's too late. So, but you want to wait because if you do it too early, even the wire and the catheter going through there can expand the VSD. And I've had that happen to me before where it's unrecoverable.
Thank you. So you're kind of in between a rock and a hard place. There's your back's against the door for timing, but then having a successful outcome, you want to wait as long as possible. That's difficult. So this is your case, which was a successful case. Beautiful example of the externalization of the wire and deployment of a percutaneous device. It's a lot harder than the video makes it look. So very nicely done.
So this was a patient that was referred to us. She had an MI probably 2 months prior to this. So she's one of those few ones that actually was able to recover and heal well. So that was a little easier than probably this case that you presented.
So unfortunately, Claire kind of declared her own hospital course. She was already very sick, but as soon as she went to the higher level of care hospital that had this capability, which was immediate, you could see that her liver was very shocky. She had significant renal dysfunction, and her LFTs were through the roof. Bilirubin is getting through the roof as well. She obviously flashed, and because she wasn't tolerating and was intubated. So at this point, I think we talked about realistically the only thing that we can do is mechanical support and just hope and pray. In terms of mechanical support, then you would suggest that ECMO with Impella would be the best.
I would put an Impella first, most likely, because you want to improve forward flow and decrease the left atrial pressure. If there's an oxygenation issue, then I think ECMO is appropriate. But then you would want to vent the LV because the left atrial pressure will increase with ECMO. So that would be my approach: is Impella first, likely. If there's oxygenation, then ask for ECMO.
And Impella is usually on the shelf, ready to go, and can be instituted relatively rapidly, and results are better. I mean, anybody who works with ECMO a lot will tell you that having an Impella in the LV on any ECMO patient with VA ECMO is superior to not having it. So Impella first and ECMO when you can.
To vent it, okay. Then to the whole panel, there are so many steps in this case that could have made for a different outcome. Just from early recognition at the primary care's office, if that was in fact the onset of the acute event, to like throughout the hospital course. Is there anything after looking at this case that you'd have offered or done differently, or could have helped?
I think the point of recognizing what shock is. So hemodynamically stable, like Dr. Brady mentioned, is not necessarily just looking at the blood pressure. And she was clearly in shock from her first labs. And so that early recognition, I think, is important.
Thank you. So this was a very complicated case, and unfortunately, we would need hours to go through every detail. But the main takeaway points is, I think one is the early recognition that even though 90% of men and women are presenting with typical anginal symptoms, many, especially females, as we learned all day, are presenting with other symptoms, which are their anginal equivalents. As said before, the early recognition in acute coronary syndrome is paramount as we start having necrosis. As our panelists had mentioned, you start having these risk of mechanical complications, which are for the most part deadly. Recognition of these mechanical complications is your only hope, but even at that point, you're really digging yourself out of a ditch. The use of mechanical circulatory support should be considered in these patients as a life-saving effort. Most of the time, a last-ditch effort, unless they could get fixed immediately. And the most important aspect of this case, I think, was how many different minds were involved. And a multidisciplinary team approach with focused clinical decision-making is a very key aspect to cases like this with such complexity. So thank you for everyone involved in this case, and thank you to the panel.